Hello and welcome back to the pharmacology session, and today we are flipping the script. Instead of talking about what drugs do to the body, we are going to discuss what the body does to the drugs. We are diving into the fascinating world of pharmacokinetics. Yeah, and that's the end of pharmacodynamics. At its core, pharmacokinetics is all about a drug's journey through the body. It's the study of ADME: absorption, distribution, metabolism, and excretion. Think of it as the drug's travel diary. You can't understand a drug's effect without knowing how it gets to its target, how long it stays there, and how the body gets rid of it. It's kinda the drug's side of story. This is the other half of the puzzle from our last episode on pharmacodynamics, which is what the drug does to the body. Together, they determine a drug's effectiveness and safety. You need both to be optimized for a medicine to work correctly. The first step in a drug's journey is absorption, the process of getting it from the site of administration into the bloodstream. Routes of administration. How you take the drug has a huge impact on absorption. So we take it like orally, intravenously, intramuscularly, subcutaneously, and all other ways like inhaled, topical, sublingual, etc. So it's self-explanatory. So oral, it's like the common route, but it has a long way to go facing the stomach acids and enzymes. IV, this bypasses the absorption entirely, which is why it's so fast. The drug is immediately in the bloodstream. Intramuscular way, it's into the muscle like a flu shot, and subcutaneous is under the skin. Others other routes like sublingual, topical, inhaled, each of them has its own pros and cons in terms of speed and bioavailability. So the factors affecting absorption. Once a drug is administered, several factors determine how well it's absorbed. Think of these as environmental condition on drug's journey. Blood flow. Areas with high blood flow like intestines absorb drug faster. Surface area. The small intestine has a massive surface area with its villi, making it a primary site for absorption. And acidity or alkalinity of the environment can affect whether a drug is in an absorbable form. And bioavailability. This is a key term. It's the percentage of administered drug that reaches the systemic circulation in an unchanged form. For an IV drug, bioavailability is 100% because it goes straight into the blood. For oral drug, it's always less than 100% because some of it is destroyed in the gut or metabolized by the liver before it gets into the circulation. This is known as the first pass effect or first pass metabolism. So that's about absorption. Now we get into the distribution part. The drug's journey through the body. Once a drug is in the bloodstream, it's not just floating around aimlessly. It's being distributed to its target sites. So plasma protein binding. Most of the drugs in the blood are either free or bound to proteins, primarily albumin. Only the free unbound drug is active. It's the part that can leave the blood and go to the target receptor. Think of the free drug as a person who gets off the bus and goes to the work. The protein-bound drug is the person still sitting on the bus. They are in transit and not able to work yet. The more the drug is bound to the protein, the less free drug is available to have an effect. So this is a common source of drug-drug interactions. And volume of distribution. This is a theoretical concept that describes how widely a drug is distributed in the body. So if the VD is low, the drug stays mostly in the blood. It's like a person who stays in the main road and doesn't venture into the city's side street. And high VD says that a drug spreads out widely into tissues, organs, and fat. It's like a person who explores every corner of the city. This value is important for determining the loading dose, the initial high dose of the drug needed to get into a therapeutic level quickly. So we have distributive barriers too. These are blood-brain barrier and the placental barrier. So the body has its own clever ways to protect certain organs. A highly selective filter that prevents many drugs from entering the brain is our blood-brain barrier. This is why it's so difficult to get drugs to treat the neurological diseases like Parkinson's is the best example. That is the reason we give levodopa, the precursor of dopamine. And placental barrier, a similar barrier that protects a developing fetus. Although it's not foolproof, it can allow some drugs to pass through. And metabolism, so it's biotransformation, the body's chemical modification lab. So the drug has been absorbed and distributed. Now our body needs to get rid of it, but drugs are often lipid soluble, meaning they don't dissolve well in water and can be easily excreted by kidneys. That's where metabolism or biotransformation comes in. This is primarily done by the liver, acting as our body's chemical modification lab. The goal is to make the drugs more water soluble so that they can be easily excreted. So imagine the drug is greasy, oily piece of luggage that's hard to carry. The liver's job is to attach handles or make it less slippery so it can be easily picked up and thrown out. So here we have almost 2 to 3 phases. So the phase 1, it's functionalization. These are the rough cutting reactions. They introduce or expose a reactive functional group on the drug molecule. So here oxidation, reduction and hydrolysis happens. And the primary enzymes, it's the cytochrome P450. It's the most important family of the enzymes here, especially in the liver. Let's think of them like a team of specialized workers, each good at a particular type of modification. Outcome, the products can be more active, less active, or sometimes even toxic. And phase 2 reactions. So these are the handle attaching I mentioned before. They attach a large polar water-soluble molecule to the drug or its phase 1 metabolite. Key reactions: glucuronidation, sulfation, acetylation, methylation. Outcome: the drug becomes more water soluble and usually pharmacologically inactive, ready for excretion. And enzymes, the activity of these metabolic enzymes, especially the P40s, can be influenced. Enzyme induction and inhibition. So yeah, the P450 is influenced. Induction: some drugs or environmental factors can increase the production or activity of these enzymes. So this will speed up the drug metabolism. It's like training your chemical workers to be faster or hiring more of them. It's like rifampin. So it's an antibiotic. It's a potential inducer of many P50 enzymes. If a patient on oral contraceptive takes rifampin, the contraceptive is broken down much faster, leading to the risk of unintended pregnancy. Or in a few cases, it's done to break the contraceptive if they want to conceive. Inhibition: other drugs can decrease the activity of these enzymes, slowing down drug metabolism. It's like slowing down our chemical workers or blocking their tools. Example: grapefruit juice inhibits CYP50 in the gut, which can lead to higher than expected levels of drugs like statins or certain blood pressure medications, increasing the risks of side effects. So it's harmful actually. And first pass metabolism, we briefly mentioned with absorption. So for orally administered drugs, a significant portion can be metabolized by enzymes in the gut wall or liver before it even reaches the systemic circulation. So this reduces the bioavailability. The drug's luggage gets partly processed in the R port before it even leaves for the final destination in the main city, that is the systemic circulation. So this we call it like the first pass metabolism. And so finally we get into the excretion part, getting the drug out. Finally, the body needs to get rid of the drug and metabolites. This is excretion. And the kidneys are superstars here. Kidneys perform the 3 main processes: glomerular filtration, tubular secretion, and tubular reabsorption. So in glomerular filtration, free unbound drugs are filtered from the blood into the urine like a sieve, removing small particles from the water. And tubular secretion, specialized transporters actively pump drugs from blood to urine even if they weren't filtered. So it's like an extra push. And tubular reabsorption, some lipid soluble drugs can diffuse back from urine into the blood. This is why making drugs water soluble during metabolism is so much important. It prevents reabsorption, ensuring they stay in the urine for excretion. So for patients with kidney diseases, drugs often need to be reduced because they cannot excrete drugs efficiently, leading to drug accumulation and toxicity. And excretion, there is other type, it's called as biliary excretion. Some drugs and their metabolites are excreted from liver into bile, which then enters the intestine and it's eliminated in the feces. enterohepatic recirculation. Sometimes a drug is excreted in the bile and can be reabsorbed from the intestine back into the bloodstream, essentially taking another lap around the body. This can prolong the drug's action. And other routes, lungs, like volatile drugs like general anesthetics or alcohols, can be exhaled. Sweat and saliva, minor routes, sometimes responsible for side effects like metallic taste. Breast milk, some important for nursing mothers, as many drugs can be excreted into breast milk and potentially affect the infant. So, from that tiny pill we swallow to its absorption into the bloodstream, its distribution to various tissues, its transformation by liver in its chemical lab, and finally its exit via the kidneys, the journey of a drug is incredibly complex and precisely regulated. And that's all for our deep dive into pharmacokinetics today. And let's, dig deeper in the next session. Until then, bye bye. Keep studying.